Good evening, everyone. My name is Ziv Haskal, and welcome to another one of the University of Virginia Department of Radiology Medical Imaging Keynote Lecture Series. If you've been a fan of our series, you know we've talked about social issues, wellness, mindfulness, health, scientific issues. But tonight we've got something really unusual. Why does it hurt? How do I stop it? How do I make it better? How do I prevent it? And what we're really talking about is ergonomics in diagnostic and interventional radiology, environmental behavioral modifications, optimize radiologists' well-being and performance. And as somebody who has lived and has the bony and ligamentous manifestations of bad ergonomics, I am really excited to hear this because I'm hoping that we'll be able to save other people problems. And our speaker is an expert on this, spoken to many surgeons on this, and has been kind enough to take on radiologists specifically in part researching this. This is Robin Riddle, who's a board-certified orthopedic clinical specialist at the University of Alabama at Birmingham. She's been doing this for 15 years. She's in her PhD for research in movement, developing interventions to minimize these very types of things on work-related musculoskeletal discomfort. Proceduralists like us, diagnostic readers, people working at community monitors, and she's spoken on this to many different types of specialties. Robin, we are very excited to have you here. Share your desktop and get started.
Thank you. All right, I think we are up and rolling, and that was definitely the best intro I've ever had. I'm delighted to be here with you all, and thank you, Dr. Haskal, for contacting me. As you mentioned, I do work at UAB, which is a large academic medical center in Birmingham, Alabama. And while I do work in the hospital, my department is outpatient. So I get to have the privilege of taking care of a variety of our own patients, including our physicians. And I like to think that I like to help to take care of the people who are taking care of others. And I just love what I do, because I get to meet so many wonderful people in the process. And that's actually how all of this came to be. One of our urology attendings came to our department just feeling exhausted in dealing with the pain and the discomfort that came from doing his work. And he was looking for help, and I'm very impressed that he was willing to ask for it. So before we begin, I have to throw in the picture of the kids. I always like to show them before I begin, so that if I come across a little frazzled, you'll understand why. So these are my 4 adorable kids. I love them so much. And also, before we begin, I have to give this disclaimer. I have given these similar lectures to many surgical departments, but this is the first time that I've tailored my content to radiologists. And radiologists are not surgeons, and there are major differences. There's procedural differences, environmental differences, equipment differences, and obviously I am not a radiologist. In fact, prior to about a month ago, the only knowledge that I had of radiology or radiologists was from Dr. Glockenflecken. And while he probably wasn't wrong, I realized I needed to prepare a little bit more for this lecture, and I really needed to better understand the work requirements and the specific environments in which the radiologist worked. The IR suites, the reading rooms, the PACs. So I was fortunate to be able to spend several hours in a few of the IR suites here at UAB and observed some procedures and checked out some workstations. Y'all do some incredible stuff. And so while I've done my best at observing and researching, I'm still not a radiologist, and I'm not you. And there's most likely certain situations that you might have in mind that may not be covered in this talk. I will leave my email address at the end, so feel free to reach out and we can try to work on a solution that fits you as well. Some situations are just plain tricky. But seriously, the knowledge in your head about literally every single structure in the human body is beyond impressive and more than slightly intimidating, I'll be honest. And the way that you apply that knowledge to just the interdisciplinary care of our patients, from diagnostics to procedures, is simply beyond me. So thank you for all that you do, both seen and unseen. So with that, let's begin with some background and rationale. Musculoskeletal disorders are injuries or disorders of the muscles, nerves, tendons, joints, cartilage, spinal disc of a person. Radiologists are at risk for developing work-related musculoskeletal disorders due to those long working days, repetitive movements, holding static or awkward positions for prolonged periods of time. And development of these conditions are associated with burnout, and they can even impact patient outcomes. Pain is the most common symptom experienced by most work-related musculoskeletal disorders. How often does this occur? Well, the prevalence of work-related musculoskeletal disorders among radiologists is high, with estimates of pain ranging from 50 to 60%, depending on what article you read. But to be honest, this is likely an underreported number. Most of these numbers that have been cited over and over are pretty old. Not all of them, but most of them. And 12% of all physicians experiencing work-related musculoskeletal disorders have to take a leave of absence. They require modifications, or they shorten their career because of it. And this can lead to millions of dollars of lost hospital revenue. In fact, the growing prevalence of work-related musculoskeletal disorders among at-risk physicians has been called an impending epidemic and the tip of an iceberg. But the good news is that ergonomic initiatives can help radiologists. So that's why I am here, and that's why we are here. And I think our time together will be very beneficial as we discuss some evidence-based ergonomic principles and strategies. So the objectives of today's discussion are to identify radiologist-specific ergonomic hazards, apply postural and environmental modifications to IR suites and PACs, perform radiologist-tailored movements to minimize work-related discomfort, and discuss physical activity strategies to mitigate that risk for occupational injuries. So on to objective number one. Let's look at some hazards specific to y'all. We'll start with the diagnostic radiologist. You all remain in front of your personal computer or PACs for upwards to 8 hours a day. And in this digital age, your entire career can be spent at a computer workstation. And unless you have a sit-to-stand desk that you utilize, you remain sitting for prolonged periods of time. Use of your computer mouse can result in tenosynovitis, carpal tunnel syndrome, cubital tunnel syndrome. And when hospitals moved to filmless environments, radiologists became more sedentary. There are wires from all of the monitors and devices, and there's no time to break because of all those stat shoulder MRIs coming from ortho. All of these ergonomic issues have been compounded recently, as many radiologists have been working from home and will likely continue to do so, at least partially, following the COVID-19 pandemic. So these factors give rise to the high prevalence of repetitive stress injuries amongst diagnostic radiologists. Now, the interventional radiologists aren't much better off. Your eyes must be fixed on the monitor screen, no matter where it is located, while performing precise movements to reach the tiniest of vessels and other structures. And if you mess up in the wrong place, it could become a bad day really quick. And when the time comes, you must compound those solutions and have strong hands to push them. Some cases are short, but others are long, up to several hours, which will require prolonged standing in some awkward positions, all while wearing those lead aprons. And in addition to your personal radiation protective equipment, you also have to tend to those shields, which often create ergonomic disadvantages because you have to reach and lean to accommodate them. So there's lots of opportunity to apply postural and environmental strategies to both of these unique environments, which is what we will do now. A lot of the media and pictures that I'm about to show are from my time that I've spent in operating rooms and surgical sim labs. But we can apply many of these same principles to the IR suite and to our computer workstations. So let's begin with the standing position. Going from the ground up, these standing recommendations are mostly geared towards our interventional radiologists when they're on their feet a lot doing those procedures, but they can also be beneficial to the diagnostic radiologist when you're using your standing desk. So over the next few slides, I'm going to have examples of poor ergonomic positions on the left, followed by more preferred ergonomic positions on the right. So in these first pictures on the left, the individual has their feet crossed, they're pointing in opposite directions, and there's uneven weight distribution. We really want to try to avoid this. So instead, by keeping your feet roughly shoulder width apart with equal weight distribution and pointing your toes in the direction of your work, you can avoid some unnecessary discomfort. So an environmental modification to promote this improved lower extremity positioning can be the positioning of your pedals. So in this first picture, those pedals are facing away from the field, and that results in a compensatory strategy of the spine having to rotate and an uneven pelvis. So we can facilitate a more balanced standing position simply by positioning the pedals to face the field. So in the case of using pedals, it's not easy to maintain that equal weight bearing in both feet. So be sure to alternate the foot that you're using to press the pedals. Maybe start with the right foot, go to the left. It's all about promoting balance when possible. Moving up the chain to the pelvis. Note in those first pictures, the pelvis is uneven. And this happens when we don't engage our stabilizing muscles of the lumbopelvic region and the core. And it also happens as we fatigue. So it's preferred that we keep a level pelvis whenever possible. Some people like to use the environmental modification of a stool, and they'll alternate placing one foot on the stool and then the other foot. When you do that, try to make sure that that pelvis is level. Moving up to the shoulders. Note in that first picture, those arms are practically parallel to the floor. And this position is going to result in an extreme amount of strain on that subacromial region of the shoulder and up into the cervical region. So it's preferred to keep your shoulders abducted to about 15 to 30 degrees for comfort and biomechanical optimization of the rotator cuff and the scapula stabilizing muscles. So we can promote improved shoulder position by modifying the table height. We want the table to be about 75% of the height from the ground you're standing on to your elbow to help keep your shoulders in a properly abducted position. That's pretty low. If the table is higher than that, it will be likely that you will have to elevate your shoulders and place a lot of unnecessary strain on your neck and shoulders. So stools can help when people of varying heights are operating. Having this table at the optimal height can reduce back, shoulder, and wrist discomfort. And now up to the cervicothoracic region. This one is just a problem for all of us. Our heads are heavy. And when our heads are in front of our bodies, like it is in this first picture, the muscles on the back of our neck work in overdrive. So it's best to try to keep our chin back and our ears over our shoulders when possible. I like to tell people, pretend like someone gross is trying to get too close to you. Or like when Kevin sees a picture of Buzz's girlfriend. That's the movement that you want to do. It's not looking up, it's not looking down, it's pulling that head back. So to help maintain good cervicothoracic positions, we need to modify the monitor position when possible. This is true in the cases of our monitors with diagnostics and with procedures. We want the top of the monitor to be as close to eye level and as directly in front of you as possible. Now at UAB, some of those monitors in the IR suites are massive. So in those cases, we want the part of the screen that you are watching to be directly at eye level. Just do the best you can. When the monitor is elevated, you have to hyperextend your neck to accommodate. And if the monitor is off to the side, you have to keep your neck in a rotated position to accommodate. Now, especially for you earlier in your career radiologist, it might not hurt in this moment. It might not bother you at all, but prolonged holds in these positions, especially when you account for the decades of time that you're going to devote to your career, can lead to issues like unilateral cervical osteophytes. We first make our habits, and then our habits make us. Now let's take it to the forearm. In this first picture, the wrist is flexed, which places a lot of excessive stretch and eccentric load of the extensor mechanism. So when possible, we want to keep your wrist in a neutral position to decrease that load. And it's hard to tell in this picture on the right, but it appears like the surgeon is holding their arms close to their body, which can help aid in stabilizing those arms when holding tools for a long period of time. So speaking of stabilizing, any point of contact that you can make with your body and either the floor or the bed or even other parts of your own body can all help to improve stabilization and decrease muscle fatigue. So don't be afraid to lean against that table to promote more stability of your body if it's safe to do so, of course. Next up, we're going to think about some strategies when we are in the seated position. All right. So the first environmental modification that you can make when you are sitting is to optimize your chair setup. Now, a lot of people will ask me about the perfect chair, and I think you'll get different results depending on what chair company is funding the research. But in general, I like chairs that are highly modifiable from the seat height, the seat pitch, armrest, and backrest. And one of the articles that we're going to discuss in more detail in a minute actually had a chair party in their department where everyone came out to the office and they tried out different chairs and they found one that everybody seemed to like. Notably, it was also a highly modifiable chair. So sometimes though, chairs aren't the only possible seating solution. We're going to discuss that in a minute. But once you've found a chair that you like, we want to make sure that you're sitting in it properly. We'll begin with the feet and work our way up. Our feet need to be firmly supported by the floor. If your feet cannot touch the floor, then you need to get a little step stool. Hanging legs will make you hurt. Your knees need to be even with or slightly below the level of your hips. Your thighs need to be thoroughly supported by your chair, leaving about 1 to 2 inches between the front of the seat and the back of your legs. Your low back should be supported by your chair. Usually, we'll discuss alternative strategies in a minute, and your forearms need to be supported by your desk. Again, usually. And a critical element is your eyes need to be level with the top of the screen, just like we discussed a moment ago. This is one of the most common mistakes I see. So remember from that standing position with the monitors, if the monitor is raised too high, your neck has to extend, which really causes a lot of cervical problems when you stay in that position over a long period of time, over several years. This is fun. I want to show y'all a fun sitting trick at your pelvis. So we're going to do this together right now. So if you're not already, go ahead and find a chair and have a seat. Okay. I want you to stay sitting right where you are and just kind of slump like it's been a long day and you're just giving in to gravity. We might not have to pretend too much with that one, right? So as you're sitting there, notice where your head is. Notice how your muscles feel. Give it a few seconds. Okay, now let's practice rocking forward and backwards at your pelvis on the seat. Don't think about your head. Don't think about your back. Just think about your pelvis. Rock forward and backwards. Do you feel those two bones that you're sitting on? Your ischial tuberosities? Find those bones. Now, I want you to place your body weight just a little bit in front of those two bones. Okay, now let's re-examine your head and your muscles. Where's your head now? Okay, and how do your muscles feel? So by keeping your weight on this point, your pelvis, your low back, your thoracic spine, and your cervical spine line up right on top of each other, which then allows your muscles to relax just a bit. You feel that? I wish I was there so I could see you all, but I bet you're all in excellent seated posture and feeling less muscle strain already. So these small changes can yield big results over time. Modifying the foundation changes everything. And best of all, this is a simple and free thing that you can do. This principle can be applied anytime you find yourself sitting. All right, let's move up and let's talk about the cervicothoracic region when you're sitting. Now, these pictures are obviously with a scope. Let's pretend that instead of a scope, there are computer screens in front of us. Note in that first picture, that chin is really poking forward and that thoracic spine is rounded to accommodate. There's so much strain happening here in the neck, just like there was so much strain happening when we were in this position and standing. Again, one of the easiest fixes you can do here is to practice tucking that chin, just like we talked about earlier. Pretend that something gross is coming by and you just want to retract. That will help to bring your cervical spine out of extreme extension and facilitate a more neutral spine. So remember our sitting trick from just a slide ago? By placing your weight just in front of those sit bones, it will be even easier to tuck that chin because you won't be working against such a harsh gravity force vector. And working from the bottom up from the pelvis and top down from the neck will really relieve a lot of that upper back and shoulder blade fire pain that we can often feel sometimes when we sit for a long period of time. Practicing new sitting habits can be tricky. So you can practice this new sitting habit while you're playing on your phone or working on your tablets. Think about rocking that pelvis forward, tucking that chin back, and before you know it, this will be second nature. Another environmental factor that you can modify while sitting at a computer is the layout of your desk. So it's helpful to think of your desk in zones. Green zones are where you want to place your frequently used items. Yellow zones is where you want to put items less frequently used or used for shorter periods of time. And then that red zone is where you want to place infrequently used items. Avoid working in that red zone. So we've discussed several strategies to modify the environment and the behavior, but what does the science, what does the research say about implementing these changes to a workstation within the radiology department? Is it feasible and does it even help? I'm so glad you asked. Dr. Horowitz et al. Out of Northwestern University Feinberg School of Medicine in Chicago recently sought to examine exactly that question. The group tested an intervention that included the development of an ergonomics committee, education, and environmental changes. And this was the group that hosted the departmental chair party. And through those interventions, they found that repetitive stress symptoms decreased, while well-being, ergonomic knowledge, perception of administrator support, and perceived control all increased. And the greatest part is that it was all low cost. And a big take home, in my opinion, from this study is that 83% of the radiologists in their department said that improving workstation ergonomic design contributed to their well-being. I feel like that's huge. Another article that's quite a bit older, but still pertinent, is this one by Bozel et al. This article suggests that ergonomic chairs, workstations, and ergonomic training can improve those repetitive stress injury symptoms up to 80%. Another systematic review that was recently published in the head and neck surgery world suggests the use of a saddle seat and an articulating arm support can help to reduce biomechanical risk factors. The saddle seat helps to drive that pelvis into the anterior tilt that we discussed previously, and the articulating arm supports can help reduce muscle fatigue, but still allow for dynamic arm movements required for work-related duties. You can get a saddle seat on Amazon for about $50, and those articulating arm supports will run about $100 each, depending on where you get them. I really debated adding this slide in because it is geared so heavily to urology, but ultimately, I chose to include it because I love the organization of this article, and it is packed full of practical tips of ergonomic wellness for urologists that I think can apply to radiologists as well. A lot of those tips have been discussed tonight and will be discussed here in a few moments. A couple of other strategies that I like to use are sitting on a Swiss ball while I'm at my desk. And that's actually a picture of me sitting on the ball while I was working on this presentation. It's very meta. But I also like using a Boppy pillow to help support my arms when I'm doing a lot of desk work at a chair without armrest. So that picture is not of me, but look at how his arms are supported. And with those supported arms, his neck and his shoulders are very happy right now with all of that support. I love the Boppy because it provides support, but it still allows for full arm motion. And you can get so many cute covers, you can personalize it, and it's a lot of fun. Okay, with our next objective comes some discouraging news that I'm sorry that I have to share with you. You could buy all of the things and make your posture and your environment absolutely perfect, but still develop pain due to the static nature of the work. And that's because over time, our postural muscles fatigue from fighting against gravity for so long. Some researchers have coined the phrase, sitting is the new smoking. And I don't really agree with that statement because, sitting isn't necessarily bad. But I think instead it should be sedentary is the new smoking, because even the most perfectly crafted position, whether it's standing or whether it's sitting, becomes bad when we don't break from that position. So speaking of breaks, we're going to take a small mental micro break for a moment and talk about something completely different from radiology. Let's think about people who are wheelchair users. Now, hang with me here. I am going somewhere with this, I promise. Did you know that there are therapists whose sole job is to create the perfect neutral position for individuals who use wheelchairs? And they have state-of-the-art pressure mapping devices that look at the amount of pressure and shear on certain parts of the body when the individual is in different positions. And they make recommendations to minimize pressure by modifying angles and utilizing inserts and materials with different densities, and by monitoring the pressure in real time through mapping. They can create a position and a seating setup that minimizes pressure and shear significantly. And they create perfect neutral positions for these individuals to minimize the development of pressure ulcers by modifying their environment. Sounds familiar. But despite this most perfect setup and fancy equipment, the individual still must change their position every 15 to 30 minutes for at least 2 minutes at a time. And they do that by tilting their chair back. We call that tilt in space. Or if an individual is able, they can lean forward and push up. So even in a perfect setup, gravity always wins. While the topic of a neutral spine and posture and environmental modifications is important, the real world, the environment, the requirements of certain activities, the presence of lead and those shields and gravity still fight against our best efforts relentlessly. So let's take our focus back to you, the radiologist. You have to get into some small spaces and maintain focus to perform precise, critical movements. Sometimes you will just not be able to be in the perfect position. And sometimes your head is going to be hanging way out in front of your body. That's okay, because while our body is usually happiest in the neutral positions, on the other hand, our bodies are also happy with movement. We develop to move. Our neck rotates so that we can move our sensing eyes and nose and mouth and ears to what we need to see or smell or taste or hear. And our spine is able to flex and extend. And it's really cool that we can move our bodies into different positions so that we can do what we need to do. The problem arises for all individuals when we maintain those positions, even perfect positions, for a long period of time. So the solution in both of these situations, from the wheelchair user to the radiologist, is to be aware of time and take breaks. Why? Because gravity always wins, unless you're rich, and then money wins, but that's another talk for another time. So I know what some of you may be thinking right now. Okay, Robin, I can't take a break while I'm working. And that makes total sense. And again, I've never been a radiologist. I do not have firsthand experience in that regards. But there's been some research on microbreaks of varying components in the surgery world, not as much in the radiology world that I was able to find, but since there are many similarities involving operating rooms and IR suites, I think that we can have some liberty to generalize some of these principles to IR. So I pulled some of my favorite research articles for you here. Now, don't worry, diagnostics, I've got your microbreaks coming up soon. I promise, and I wouldn't lie to you because you could see right through me. So this first article by some head and neck surgeons from Quebec, Dorian and Darvaux, they sought to evaluate the effectiveness of a micropause on muscle fatigue, accuracy, and comfort. And the micropause was simply a 20-second break performed every 20 minutes. The micropauses almost completely prevented the effects of fatigue associated with surgery. The second study here by Park et al. Aimed to evaluate the effects of targeted stretching microbreaks on pain and fatigue, mental focus, and physical function. And these microbreaks improved their pain scores, improved their perceived physical performance and mental focus. And here's the kicker, it didn't extend their operative time. This third article, designed as a randomized control trial to examine the effects of intraoperative breaks on mental and somatic operator fatigue. So the procedure being performed was complex laps in children, usually requiring over a couple of hours of surgical duration. The primary outcome was hormone stress response, and the secondary outcomes were mental focus, musculoskeletal pain and strain, fatigue and stress, and what they called intraoperative events. So the stress was measured by salivary cortisol levels every 30 minutes, and mental focus was measured pre and post-op by a concentration test called the BP test that measured concentration and error rates. Musculoskeletal pain and strain, as well as fatigue and stress, were measured on a 0 to 10 scale. And they defined those events as anytime there was an increased heart rate of the surgeon greater than 30%, or heart rate increase greater than 20%, plus a specified context like loss of exposure or bleeding or difficulties performing a motor action like dissection or tying a knot. The IPP group was the experimental group that performed intraoperative breaks. They would do 25 minutes of work followed by a 5-minute unstructured break. And that reminds me of a Pomodoro technique when I read that. The CPP group was the control group, and they just performed conventional procedures. They had some really interesting results. So the saliva cortisol levels of the surgeons operating without breaks were significantly higher by 22% than those of the surgeons operating with the breaks. For the musculoskeletal strain and pain scores, there was significant improvements recorded. The intervention group had significantly decreased reports of musculoskeletal pain compared to the control group. And it's interesting to note the regions where these differences were noted include the spine and the extremities, which are areas where both static positions and repetitive movements are performed. So the concentration and performance test results in the control group from pre to post-op have a decreased performance score and an increased error rate, where in contrast, the intervention group maintained the overall performance and error rates. The intergroup differences for performance were significant, and while the scores for error did not quite reach statistical significance, the intervention group error rate was still threefold lower than the control group error rate. This article also noted that there was no change in surgical time, which I thought was shocking, between intervention and control groups. But I think a lot of the reason for that is because the surgeon was able to come back and feel less pain and have better accuracy and concentration. And so our literature suggests that musculoskeletal pain increases risk of injury, increases your risk of burnout, while decreasing productivity, quality of life, accuracy, and patient safety. But microbreaks, just short little breaks, can increase self-reported physical performance, accuracy, and concentration, while decreasing pain and discomfort, cortisol level, fatigue, and stress at no cost to surgical time. So the evidence suggests that microbreaks within a sterile environment may be helpful and may be feasible, but there is no standardized adoption of these microbreaks, even in the surgical world. And I personally think that implementation of these strategies is a critical piece of the ergonomics puzzle. And that complexity, I think, lies in the fact that the radiologist and the IR suite, is not just a standard worker in a warehouse, and that's what makes implementing these microbreaks really tricky. What we do know is if we are to perform these microbreaks, they must be crafted to suit the considerable work-related demands of the IR suite and be meaningful for the radiologist while considering the utmost in patient safety. And we need cues to remember to do them. I hear so often, I just forget. It's been 3 hours and I just forgot. So we need to be proactive. We need to set timers, clocks, apps, using music to remind us to take some of these micro breaks. So what exactly do I do during a micro break? Well, the good news is you're in charge and you have control over what you decide to do and what works best for you. Some of the evidence supports that micro breaks from anywhere from 20 seconds to up to 5 minutes, which I feel like is really long, can be effective, but we really aren't sure which method is superior. I'd argue that different movements for different specialties may be indicated, and even physicians within a subspecialty may need different micro break strategies dependent on their own personal factors. At UAB, we just developed a surgical ergonomics program where a therapist observes a physician while they're performing a troublesome procedure, and the therapist provides some highly personalized recommendations. All that to say, I don't think this is a one-size-fits-all situation, but I'll show you a few possibilities of what you can try the next time you're in the IR suite. Be sure to tell me which one seems to work best for you. Send me an email at the end. So the randomized control trial that we reviewed earlier examined 5 minutes of unstructured time. The surgeons did not scrub out. They also did not perform a certain thing. So that could be an option. You can just check out for a minute. Contract relax is similar to progressive muscle relaxation in that it helps to relax muscles through 2 steps. First, you systematically tense particular muscle groups in your body, like your neck and your shoulders, and then you purposefully release the tension. And you're particularly mindful of how the muscles feel when you relax them. I'll show you some stretching and active movements on the next slide. There's some interesting research on power poses as well as diaphragmatic breathing, just simply breathing in for a few moments, breathing out for a little bit longer. A lot of that can deregulate the sympathetic system, and I think promote some of the decreased stress, improved feelings of wellness. So these are a few of the active stretching movements that you could try. So I call this river dance on the left. It's a great neck stretch when you've got that cervical pain, where you reach down towards the floor with your palm, and then you side bend your head to the left and then slowly to the right. That can get you a nice stretch in that neck area. The next one I call the OG because it's the very first micro break option that I recommended a few years ago. It is very aggressive in that you're reaching overhead, you're keeping your arms overhead, and you squat and stand about 10 or so times. That one definitely gets the blood pumping. And I really like, as a therapist, I like that it wakes up your glutes, which are powerful postural muscles. But I learned really quickly that not everybody likes to squat, and that's okay. And then you see the stick 'em up on the right, where you bring your arms up, your chest comes forward, and you can really feel the anterior aspect of your trunk opening up with the arms overhead, and you get a nice chest stretch as well, which feels great after you've been forward for so long. Adding in a little bit of rotation at the spine is an option if you feel safe to do that. You can even come up with your own micro break. You might have a movement that you like to do. Maybe you like to dance for a few moments when that good song comes on the radio. Now, for the radiologist that's not working within a sterile environment, your time is prized. You've got so many scans to read. So strategies to reduce discomfort outside of the sterile field still must be quick. They must be meaningful, and they must be customizable to your unique needs. Some tools that I'd recommend to have on hand near your workstation or at home or in the physician's lounge for your use are a Theracane, a couple tennis balls, and even some bed sheets. So with a Theracane, you can target those hard to reach trigger points around your scapula and your thoracic spine, as this picture shows. You can also hold it static for a period of time, like 30 seconds to a couple of minutes, or you can incorporate some movement with that pressure. I have one of these at my house, and I'm not in any way affiliated with Theracane, but I do like to use these. Tennis balls can be your best friend too. I'd recommend having some singles, and then also you can tape two together to form a fun thoracic spine mobilizer. This first picture that you see her placing that double tennis ball at her thoracic spine, leaning up against the wall and then raising those arms up and down. This is a great way to open up your chest and fight against that forward posture that we are in so much. This second group of pictures is for anyone who may have some shoulder issues. So you don't necessarily have to lay down for this, but being in that side-lying position does help to stabilize the humerus. You could do this up against a wall too. So imagine the mat is the wall and that he's standing up against it. And basically what you do is you push that tennis ball right into your axilla. You are targeting the subscapularis muscle, which is a very strong internal rotator that is on the anterior aspect of that scapula and is a notoriously tight fellow for anyone that is working with their arms in front of them for prolonged periods of time, like radiologists. After you place the tennis ball deep in that armpit, you keep your humerus still, but you rotate your hand forwards and backwards, doing internal and external shoulder rotation. Now, I dare you to try this one and not scream a little bit. It could be surprisingly tender. For both of these movements, I do them maybe 1 to 2 minutes. I don't think I've met a single person that does not need to do these stretches. And I think it's the result of the digital age that we live in. We are always so forward, and these muscles can get tight fast. So you can use that bed sheet that we talked about a moment ago to help stretch out your scalenes. You can keep that sheet folded such that it's about 4 or so inches wide. And then you can sit on one end of it and then bring it up and over one of your shoulders as close to your neck as you can be. You have to make sure that your chin is tucked. This component is critical. And if you like this stretch, or if you try this stretch and then you don't feel it much, it's probably because your chin isn't tucked. Okay, so that part is critical. After you ensure that chin is tucked, you want to tilt your head away from the sheet and then gently rotate your head and look up towards the ceiling. This one's tricky because usually when people rotate and look up, they lose that tilt or they lose that tuck. But I know that y'all will get it just right because y'all are super smart. Okay, and then the second group of pictures is a levator scapula stretch. This is a good one for us to do together right now. So this is the muscle that's just medial and superior to that medial border of your scapula that just straight up burns sometimes. For this one, you'll want to be seated because grabbing the underside of a chair or sitting on your hand is a critical component of this stretch. So once you've anchored your hand by either holding the chair that you're sitting on or by sitting on your hand, I want you to rotate your head away from that hand and then look down. It's kind of like looking at your opposite armpit. Theoretically, the recommendation is to hold a stretch for a total time of 60 to 90 seconds. So 2 or 3 sets of 30 seconds is a good number to shoot for your stretches. Finally, moving on to our final objective. We are now going to briefly talk about lifestyle behaviors outside of work that play an important role in feelings of wellness while working. I feel like this section could be a whole weekend retreat, but we will keep it short and sweet today. The bottom line, you need to think of yourself as an endurance athlete. You have trained for the mental stamina component of your job by studying for more than a decade, and you can't expect your physical stamina to just adapt to the physical requirements of your job without training it as well. So your out of the office program needs to consist of aerobic and strengthening components. Current CDC recommendations are about 150 minutes of moderate intensity aerobic exercise a week or 75 minutes of high intensity aerobic exercise a week, in addition to 2 days of strength training in the least. With that said, it's important to remember even 5 minutes of something is better than 0 minutes, you know? So when your body is conditioned, it's better able to tolerate those stresses and strains that come with your work-related duties and those lead aprons, especially after implementing the ergonomic principles and suggestions that we've talked about today. So for aerobic exercise, I recommend doing something that you love: dancing, gardening, biking, hiking, kayaking. There's lots of ways to get that heart rate up, and some are more fun than others. The aerobic exercise that is best for you is the one that is fun that you will do. For strengthening exercises, we want movements that make your muscles work harder than usual, at least 2 days a week. That's the current recommendation. There's lots of strength training programs out there, but in general, for people doing a lot of sitting and a lot of standing throughout the day, I like to recommend posterior strengthening. So think extension, focusing a lot on the back and the core, your quads and your glutes, your scapula stabilizers. All of these major muscle groups help stabilize and support the body during those long working days. I've compiled a list of recommended movements that for time's sake, I can't include in today's talk, but if you're interested, you're welcome to shoot me an email and I can get those straight over to you. Okay, we're wrapping up, but I want to mention a couple of special considerations. Pregnancy can be even more demanding on our body, and it can create a lot of problems on our body. So because of that, I recommend that pregnant radiologists use a pelvic support band early on, which can help with back pain and bladder urgency. I recommend that you sit when you can, and also use compression stockings and supportive shoes beginning in the second trimester before foot pain or swelling gets out of hand. Flats are probably not the best shoe to wear when you're pregnant and standing for long periods of time. Instead, opt for a great tennis shoe. Also, a board-certified pelvic health physical therapist can be your greatest asset and your greatest friend during and after pregnancy. You can find one in your area by going to aptapelvichealth.org. And finally, the hurting radiologist. A lot of these techniques are preventive in nature. They help to minimize the onset of more serious disease. When musculoskeletal disease is already present, it may be important to go ahead and seek further medical care and attention. So if this is something you can relate to, do it earlier rather than later. You are worth it, and your patients are relying on you to be at your best. This work is an evolving collaborative effort by many people, including therapists and students and physicians and health behavior experts and my colleagues and friends at Spain Rehab. And I have several slides of references to go through here. I'm happy to provide these in a Word document if you're interested. And finally, this has been a lot of fun. I'm always open to collaboration, and I'm happy to take any questions or hear any comments or other input from others. And feel free to email me.
Robin, thank you very much. Let's unshare your screen so we're back to full screen. That's wonderful. We may be joined by Rebecca Dameron, who's our co-discussant from Diagnostic Radiology. That was spectacular. I was trying to do some of these things, and I must tell you that breaking some bad habits, trying to figure out how to get that actual chair positioning. And I have so many questions, but perhaps some ideas about wrist and hand positioning over mice beyond the support of the chairs and upright and things of that sort for repetitive stress disorders and wrists and otherwise. Anything, comments you want to give us?
Absolutely. It's really key to keep that wrist in the most neutral position as possible. If you are in an environment where you have the ability to adjust a table, the most common issue that I see is when the table is too high and then you're holding those tools and you end up extending those wrists like this. That's going to put a lot of strain on those lateral structures at the elbow and create a lot of forearm pain. So neutral wrist as much as you can, being sure to stretch out the flexors and the extensors are kind of basic strategies to use there as well. Another great strategy that I like to use myself when I start to feel a little bit of discomfort in my forearm is I will do what's called a pin and stretch. What that is I take my own hands, I get on the area of discomfort and I pin it down. And after I pin it down, I also pull it towards my elbow proximally. After I do that, I can move my wrist in different directions and get a nice stretch and a nice release on a lot of those structures. Don't forget your pronators and your supinators as well. So really getting into the medial aspect of your arm here, pinning down those muscles in between the radius and the ulna, and then getting some rotation can also get a lot of great muscle release as well. So the pin and stretch is a great strategy that you can use to help with those wrist and forearm pains that I like to use a lot.
Spectacular. You mentioned a lot of resources, and we will gladly post them with your lectures so that everybody who visits afterwards can have them right there. So we'll take everything from you and make it available. Thank you.
You got it.
Want to say a word about standing desks and fashion or fabulous, or maybe yes or no?
There has been some studies on sitting versus standing, especially in the dermatology world, actually. And a lot of the research finds that there's really no difference. You know, if you want to sit, sit. If you want to stand, stand. But what I do find that is interesting and that I think warrants a little bit more research is looking at the alternating up and down. It's not strong in the warehouse world, in the world of typical office environments. Evidence really isn't strong that suggests one over the other. And I think that's because we're all built differently and we all come with our own personal factors that are different from the next person. We've all had our experiences, we've all had our injuries, and we all have our different environments. So I think finding something that works for you is going to be the best strategy. I will add, though, that the use of those anti-fatigue mats is also debated in the literature, but they do see and they do find that people who are more prone to develop back pain might have a better response to those anti-fatigue mats versus somebody who doesn't already have back pain. And they hypothesize that it's because it provides just a little bit of movement at your feet, which then activates a lot of our stabilizers. So I think a key takeaway can be alter your surface from a static surface to a slightly movable surface, like those Swiss balls, or standing on an anti-fatigue mat. Anything that just naturally and subconsciously gets your body moving a little bit can help to mitigate some of that postural fatigue related pain that comes from being in the same position for such a long period of time.
Rebecca, feel free to chime in at any point with anything that you want to throw in.
This is great. I came from a long stint in private practice, and we had complete sort of decrepitude in our group. Everybody in the group was having so many orthopedic issues. The hospital dispatched a PT to come and assess each one of us because we were such a mess. But the first thing we developed, interestingly, was flexor and extensor tendonitis in our elbows from the mice. Like if you're a diagnostic radiologist and we were doing, 14-hour days, it was this horrible elbow pain, which got every single one of us. So we were coming to work in braces, using our left hands. And we eventually found the only truly vertical mouse on the market, which is an Evaluant Mouse, which it's completely vertical. So you can hold your hand in this perfectly ergonomically appropriate. So you don't have to dorsiflex to use the buttons. I should have brought it home, but I didn't bring it home. It's at work. It's actually not very expensive, but it was a game changer for me and for many of my colleagues I was at the point where I was basically a one-handed human because, all this PT and everything, but that mouse really kept you from dorsiflexing all day long, which was super great. I mean, I've used every single thing you've said. I've used, the compression socks, because even though, you just sitting all day and doing all these repetitive trauma things are tough. So we had these PT come in and fit us to our chairs and our desktops and all these things that you've been talking about. It was incredibly helpful. And we were all in PT anyway, because none of us could move our right arms. So, it was great.
So I want to use that to emphasize, as Dr. Dameron and I being later in our careers, and your point that, looking at younger people early on in trainees who naturally think that they're invincible, impermeable to X-rays and all those types of things. I grew up working in rooms that are the worst ergonomic ones. Designs have improved. Tables are still too high for me, but they used to be even higher. Monitors that were off to the side. I have those unilateral osteophytes when I turn my head that you describe, and all those things worked out over a career. So these really are, and that axial loading and the C-spine DJD from working in extension, looking up with loading. So, an echo of all the things that you're saying to everybody who's listening, that the time to think about these things is now. And when you go and visit, for example, medical manufacturers who sell us these devices that you saw in IR labs, then, when they're putting these things together, I've seen them take forced breaks where all workers get up, and while they're playing music and talking to each other, and they're doing all these kinds of exercises and mimic the things that you have. And this is simply a workplace habit while you're chatting about things to the people you work with. And we don't have that kind of culture that industry recognizes that productivity and worker health depends upon. So you're talking to us about trying to build it in at this point early on for productivity. So, you don't have stories like mine and Dr. Dameron. So, bravo message to everybody out there. Watch this talk and repeat these exercises.
And I'll add to the behavior component. You bring up such an important point, because we can talk about this and we know that these things can be helpful, but implementing and doing a new behavior requires effort, and it requires a lot of components, not just your beliefs, but what your coworkers are doing, what your attending is doing, what your hospital is doing. There's a whole socio-ecological model that goes into our behavior. Then when you look at behavior itself, there's components like your knowledge, your attitudes, subjective norms. Are my friends doing this? And then a perceived control. So if you know these things are possible, but you don't feel like you have control or the ability to do those things, then you're not going to do those things. So there is a whole realm of behavior theory that goes into the implementation of some of these things. And I think that's why it's been difficult to implement in the surgical world and probably in the radiology world as well. And that probably needs a little bit more discussion as well.
Support from the top
Yes.
and support from the culture. There you go. I think we're coming up on our time. I want to thank you so much for this and for doing the work to customize it to us and give us these materials. I'm looking forward to getting those extra things that we can post with your lecture. Thank you so much for gracing us with your expertise.
It's my pleasure. Thank you very much for having me.